The first of the 5 principles that we're going to talk about is drug administration. Have you ever thought about how many different ways drugs can be administered? So on the left-hand part of your slide are 3 broad categories. Enteral means that you as an individual actually take the medication past your lips or through your mouth. Parenteral is anything that doesn't go through this route. Other is a whole range of other modes of administration. So let's look at the picture to help us. So enteral includes everything that is going through this orifice, the mouth, in addition to per rectum, as in a suppository, and in the mouth but underneath the tongue. So enteral routes of administration include oral, PO, rectal, PR, and sublingual. Parenteral, on the other hand, is shown over here. And this includes giving drugs intravenously, shortened as IV, intramuscularly, shortened as IM, or subcutaneously, just underneath the skin, referred to as sub-Q. Other routes of administration that we're going to talk about in the next couple of slides is giving medication across the skin. This is referred to as transdermal. Another way is topically, giving the drug only to the site where you want it to go, for example, eye drops. Another example is inhalation, actually breathing in a medication. Patients with asthma use inhalers. That's probably the best example of inhalation as a route of administration. And then there's intranasal, when you have a bad case of allergies and you use some type of sinus medication. You sniff it up your nose, and that is referred to as intranasal. So a multitude of different routes of administration. So how is it decided what is the best route? Well, for some of these, we're going to look at the pros and cons of different routes of administration. And by far and away, the most common way to give a drug is by mouth, or PO. The obvious advantages are the following. Easy to use. You write the prescription, the patient takes it home, gets it filled at the pharmacy, and takes it according to the schedule that has been advised. So it facilitates outpatient care, which is obviously much cheaper than any type of supervised care. And as a result, it has a lower cost margin. It's, generally speaking, cheaper to make pills than it is suppositories, sublingual preparations, or IV preparations. However, on the flip side, there are disadvantages. Even though swallowing a pill can be defined as easy to use, it is, from a pharmacologist's perspective, actually the most complicated path of administration. And because it's complicated, there is this element of variability in response. You might ask, well, why? Well, here are some of the reasons that contribute to a variable response after swallowing a medication. One is, does food in the stomach increase or decrease the ability of the drug to get from the stomach into the blood supply? Does the pH of the stomach, i.e. the acidity of the stomach, in any way impact how the drug is going to move from the stomach into the blood supply, or from the intestine, anywhere along the GI tract, into the blood supply? Then there's the concept of first pass effect. And we're going to spend a little bit of time talking about the first pass effect. And then finally, biotransformation in the liver and the gastrointestinal tract, called GIT for short. Biotransformation refers to a manner in which a drug is altered prior to it actually getting into the liver. So let's look at this first pass effect. So in the top, in the left-hand box here, we have oral administration of a drug. Where does that drug go? Well, follow the red line down and you can see it going down along here. You can see throughout the GI tract, you're getting absorption across the GI tract. Where is that absorption going to? Well, it actually gets absorbed into a very large vein called a portal vein that goes from the intestine to the liver. The purpose of this vein is actually to transport nutrients primarily, but it will also transport any drugs that are administered by mouth. When the drug reaches the liver, it can undergo biotransformation or metabolism, and as a result, less of the drug actually reaches the circulation shown here as the vena cava. So orally administered drugs have to travel down the GI tract, have to be absorbed across the GI wall, have to be absorbed into the portal vein, have to be presented to the liver, and then have to be exported from the liver into the blood supply. That is why we call oral administration of drugs the most complicated path. There are so many steps involved and so many different processes can occur at each of those individual steps. Looking at first pass effect more closely. First pass effect is a very, very important principle in pharmacology. So on the left here we have the dose of the drug. It is swallowed by the patient, and we can see that the drug travels down the GI tract reflected by this orange tube here. Some of the drug is going to be excreted in the feces through the rectum. A large portion of the drug, you hope, is actually going to be absorbed from the lumen, the opening, of the GI tract into the cells that line the GI tract, and that is these cells here. These are referred to as GI endothelial cells. The drug passes across the endothelial cells and gains entrance to the portal vein. The drug is then carried in the portal vein along with all the other absorbed nutrients from the GI tract to the liver. Some portion of the drug is metabolized in the liver, and the remainder of the drug is excreted into the vena cava, one of the major blood vessels in the body, and circulated throughout the systemic circulation. So as you can see here, there are several points that contribute to variability along the potential path for drug absorption. Moving on, rectal administration. We typically refer to this as the use of suppositories. The advantages, questionable relative ease of use. There are societal norms that vary in their opinion with regard to relative ease of use. Can be used in the outpatient setting and as a result is relatively low cost. The things you don't have to worry about with PR administration is you don't have to consider the effect of pH in the stomach primarily, or the effect of food in the stomach because you are giving the medication per rectum. However, tolerability you need to consider under two headings. Tolerability in terms of it doesn't cause any GI upsets such as heartburn, but also maybe there's a negative element to tolerability in terms of acceptance of suppository use. Disadvantages. A less complicated path for sure, and as a result, a less variable response. The reason why we put less in parenthesis is because a first pass effect can occur, but to a much smaller degree than if you were to give the drug orally. So only some percentage of the drug will be subjected to biotransformation in the liver. So let's look at this same picture again, and now we're referring to suppository use, rectal administration. The vast majority of the drug is going to enter into the vena cava directly across the submucosa of the rectum. A very small percentage of the drug may travel proximally up here and enter in through the portal vein to the liver. But the vast majority of the drug is going to be exempted from the first pass effect. And for this reason, it is considered a less complicated pathway for administration of drug. The next one to discuss is sublingual administration. The best example of a drug that is given sublingually is nitroglycerin. Nitroglycerin is a drug that is called a vasodilator. It opens up blood vessels. It's used in the treatment of angina in people who have chest pain because of poor blood supply. Nitroglycerin is typically administered under the tongue and gets very rapidly absorbed and gives rise to vasodilation and most commonly a resolution of chest pain. So the advantages of sublingual administration can be described as follows. Relative ease of use, you pop something underneath your tongue, can be used in the outpatient care, and as a result cost containment is an advantage. It has a very rapid onset of action, and I would emphasize this point. All of you probably know that the lining of the mouth, the oral cavity, has a very, very good blood supply. So if you have a molecule that can be absorbed across the buccal mucosa, that lining of the inside of the oral cavity, it can get access to the systemic circulation very rapidly. And it can do so by bypassing the stomach and the intestine. And this is a real advantage because it eliminates the first pass effect. So a much more direct route of administration for the user. Disadvantages can be, not always, can be that sublingual preparations are more expensive to make, and that cost, unfortunately, is often passed on to the consumer or the insurance companies. Taste, tolerability, acceptance on the part of the user can be an issue. Another example of a sublingual medication is medications that are used for the treatment of allergy. So a trademark, for example, would be Claritin. As a sublingual medication, loratadine dissolves very rapidly underneath the tongue and has a very quick uptake, but has this kind of sour, acidic aftertaste. There are naturally limited numbers of medications that are available by sublingual administration. So certainly a lot of advantages and fewer disadvantages. Moving along, if we give a drug intravenously, in parentheses there is intraarterial, which is exceptionally rare to give drugs intraarterially, but is included here for completeness sake. So if you give a drug by IV, the advantages are, again, no first pass effect. You are giving the drug directly into the systemic circulation. So you have a better sense of what you give is what's delivered. As a result, you have this ability to control the dose of the drug that's delivered. You also have a very strong advantage of a rapid onset of action. Any of you who have had the misfortune of receiving an IV infusion at any point in the past will know that there is a lot of care involved in how the IV infusion is set up. As a result, the cost is higher because it requires more equipment. There is, of course, the potential of unintentional overdosing, and as a result, inpatient supervised care is typically required. So the real plus of IV administration is you know what you're giving, you know it's going to get there. The disadvantages are it's more painful for the patient, more costly for the healthcare system in general, and this potential of unintentional overdosing. We are seeing an increase in the use of intramuscular administration. The advantages, again, bypasses the liver, the intestine, and the stomach. It depends on whether the solution that the drug is mixed in is aqueous or non-aqueous, because this will determine the rate of onset of action. So if the active part of the drug is dissolved in an aqueous solution, then you can expect a fast onset of action. If the active moiety, the drug, is dissolved in a non-aqueous solution, then the onset of action is slow and sustained. This is actually an advantage. We use this chemical knowledge to decide how we formulate intramuscular drugs. So let's say, for example, we want to give a sustained preparation of a contraceptive pill, and we want the effect of that pill to last for 3, 6, or 9 months. We can encapsulate that medication, the active component of the contraception, the estrogen and the progesterone, in a non-aqueous solution. And this is now referred to as a depot preparation. We also use this commonly in psychiatry when we use drugs for the management of long-term conditions such as schizophrenia, where a class of medications called neuroleptics are used. We give those as depot preparations. There are, of course, disadvantages. It is an invasive procedure. Anybody who's had an intramuscular injection will know that it is actually quite painful. The development of IM preparations are more expensive relative to the development of pills, tablets, or capsules. It does require absorption from the site of delivery. So when the site of delivery is selected, which is usually in the buttock area, the requirement is that that area has a good blood supply. So you require absorption from the site of delivery. Typically, IM injections require some level of supervised care, so it raises the level of supervision that is necessary. Moving on to subcutaneous administration of the drug. So heparin is probably one of our best examples of subcutaneous administration. The advantages here again are bypassing the liver and the stomach. Same issues: aqueous solution, fast onset of action. Non-aqueous solution with the intention of a slow and sustained release and a slow and sustained response. Examples again here: heparin, short-acting insulin. Any diabetics out there will have a lot of familiarity with sub-Q administration of insulin. Non-aqueous solution, again, there are contraceptive preparations available that are subcutaneous. Disadvantage: it's breaking the skin. So pain, infection, skin necrosis if you continue to use the same site repeatedly. So those individuals who require chronic subcutaneous administration, we vary the sites of administration, particularly for diabetics who are requiring subcutaneous insulin in the chronic setting. These are more expensive drugs to formulate, so that needs to be considered. Supervised care may be required. For insulin, not typically. Patients are well educated and become very familiar with self-administration of insulin, but heparin commonly is administered in the inpatient setting. Now we have a host of other modes of administration, and these are growing in popularity. First of all, transdermal. This is the concept of using a skin patch, where you apply the patch which contains the active moiety, the drug, embedded within the center of the patch, which is usually contained with a different substance. It's applied to the skin, and the drug is slowly absorbed across the dermis, across that layer of the skin, to gain access to the systemic circulation. So it again bypasses the first pass effect. There is the real benefit of improved compliance. Most transdermal administration modes require once-a-week administration or even once a month. So this improves compliance because it diminishes, or it reduces rather, the amount of remembering that the patient has to keep in the forefront of their mind. Lipid solubility of the medication will absolutely determine absorption, and we'll explain this concept in more detail in the next section. To give you some examples of the ever-growing spectrum of drugs that are used in a transdermal mode. An antihypertensive drug, clonidine, is used as a once-weekly patch. The analgesic, fentanyl, and lidocaine, long-term management of people who have chronic pain. The antiemetic, scopolamine, anybody who likes to sail. Using the patch behind the ear, scopolamine is a very effective antiemetic, a drug that reduces nausea and vomiting. Smoking cessation, the nicotine patch. Contraceptives, the estrogen and progesterone patch. Anti-anginal medications. These are medications used as vasodilators to reduce chest pain caused by poor blood supply. Nitroglycerin is an example here. Dementia, Recently, we have seen the approval of rivastigmine used to try and control the rate of memory loss in patients with a known diagnosis of dementia. So transdermal delivery of medication is an ever-expanding route of drug delivery and one that has real appeal by the end user, the patient. Topical drug delivery is a vast spectrum for consideration. The idea here is very simple. It's you're delivering a drug directly to its site of wanted action. The one that probably jumps to mind for most of you is dermatology. There is an adage in dermatology, if the condition, the rash is wet, dry it out. If the rash is dry, then use some type of lubricant. So steroids, steroid creams, emollients, Neosporin, which is an antibacterial cream that is applied to infected areas of the skin. So this is a very common use of topical drug delivery, remembering that the skin represents a very vast surface area. But ones that may not necessarily come to mind is intraocular administration, so eye drops, artificial tears for people who suffer from dry eyes, antibiotics for people who have an eye infection. In the elderly, glaucoma, which is an increase in intraocular pressure, is treated by giving a class of drugs called beta blockers. So directly administering the medication to its intended site of action, with the idea being that there's limited systemic circulation or absorption into the systemic circulation. This is highly appealing. If we go back to my earlier comment, we swallow an aspirin pill to cure a pain in our little finger. This is the idea of dropping some eye drops directly into the eye and not having any effect beyond the location where you want it. Contraceptives, so intravaginal administration of drugs, spermicides is your best example. And then intrathecal or epidural. The best example here is in pain control during labor and delivery. Other is the administration of chemotherapeutic drugs. These are drugs used in the management of cancers that affect the brain and the spinal cord. We have the capacity to directly administer drugs into the intrathecal space along the spinal cord, so direct administration to the site of action. I would add one final comment to this concept of topical drug delivery. Throughout additional hours that we will be spending with you, we will talk about this concept of targeted drug delivery. It is our knowledge about topical drug delivery that allows us to extrapolate into the concept of targeted drug delivery. So all of the topical drug delivery methods are easily accessible. The eye, the skin, etc. But let's say, for example, we want to target the liver or we want to target the lung. These are additional concepts of targeted drug delivery with the idea that you get the drug to the site of action and you minimize the delivery of the drug to other sites, thereby trying to minimize any element of toxicity. So the last two modes of administration include inhalation. So this is breathing in medications. The attraction here is that you can have very rapid delivery of large volumes of drug over a large surface area of the respiratory tract. So remember, the respiratory tract is the trachea, the bronchus, and then the alveoli. We have two lungs, each of us, in the normal state of health, and this provides a very large surface area for absorption of drugs from the parenchyma, the tissue of the lung, into the surrounding blood supply. And the advantage here is the lung parenchyma is very permeable. So it allowed small molecules, small proteins, which are referred to as peptides, to cross across the membranes in the lung parenchyma and the surrounding vascular tissue, and therefore you get the drug into the surrounding blood supply. This is aided and abetted by the concept that not much metabolism of drug takes place in lung tissue. Some does, but not very much. So you have rapid delivery, large surface area, no first pass effect, and very little in the way of metabolism. The downside is the size of the molecule can be a challenge. So the larger the molecular size of the drug, the more difficult it is to cross the lung parenchyma. So you decide on your method of drug delivery knowing about the structure, the molecular structure of the drug itself. So what are some examples where we use inhalation as a mode of administration? Probably the most common is if you've ever had an anesthetic. So we use anesthetic gases in addition to intravenous drugs to help put patients to sleep and to eliminate pain response during surgical procedures. Another very large category is drugs used to treat asthma. Now, in this situation, you could actually argue that this is an example of topical drug delivery, but not really. So even though you inhale the drug and you do dilate the airways directly in the drug, directly in the lung, you also get systemic absorption of the drug to enhance that local effect. Insulin for diabetes. We now have an inhaled form of insulin, which has the potential to provide a huge advantage in terms of acceptance and tolerability for patients as an alternative to subcutaneous insulin administration. And this is a real advance in human pharmacology. And then consider the downsides. There are two common examples of illicit drug use. Probably the most scary is the concept of huffing. This is the idea of inhaling volatile gases for the purposes of obtaining an emotional high. The illicit drug use of marijuana and cocaine are two additional examples. And then obviously the social activity of smoking cigarettes. The inhalation of nicotine gains very rapid access to the systemic circulation. And then finally, intranasal administration. So just think for 1 second the difference between inhalation and intranasal. When you administer a drug intranasally, you go through the active process of an intense sniff through the nose, whereas inhalation is the rapid intake of breath through the mouth using a device. So the intention with inhalation is for the drug to get access to the trachea, the bronchi, and the lung parenchyma. The intent of intranasal is direct absorption across the nasal passages. So nasal mucosa, much like the mouth, has a very good absorptive area. So intranasal administration is sniffing in a drug such as vasopressin, which is a hormone with the intended action being within the brain. We also, the flu vaccine, introduced a couple of years ago as an intranasal mode of delivery for a vaccine. It is highly beneficial for drugs which are predominantly peptides because they have this access across permeable barriers that allows access to the systemic circulation. An additional potential yet to be proven benefit of intranasal delivery is that drugs can cross the blood-brain barrier. So at the very top of the nose is what's referred to as the cribriform fascia. This is an area of relative weakness in the blood-brain barrier that permits drugs getting access into the brain, the circulation within the brain that would otherwise not get access to these areas. So that's intranasal delivery of medication. So let's take a little break here and see how we're doing in terms of your understanding. How many methods of drug administration can you remember? So think over the last couple of slides and see if you can come up with the vast majority of the different routes, and we did discuss a lot. So here they are: by mouth, per rectum, sublingual, intravenous, intramuscular, subcutaneous, inhalation, intranasal, topical, and transdermal. So an additional question. What is the first pass effect? So your options are: the first pass effect refers to the absorption of a drug from its site of administration, or it refers to how the drug reaches its first site of action, or it's how the amount of a drug can be reduced by metabolism before it reaches the systemic circulation, or finally, it is how a drug is metabolized after it reaches the systemic circulation. So which option would you choose? first pass effect? So the answer to the question is first pass effect refers to how the amount of a drug can be reduced by metabolism before it reaches the systemic circulation. I am sure that there are many of you out there who may have chosen the answer D. The difference between the two is D refers to the mechanism whereby the drug is metabolized, whereas C refers to the principle of how the amount of the drug can be reduced by metabolism. So a little bit of a tricky question there, just to make sure you're all on your toes. So we'll take a break here.